Well, hi, everyone. Welcome to another Shop Talk. My name is Chad Cook, and today on Shop Talk, we have Dr. Suzanne Snodgrass. You probably have read her work, and she is from Newcastle, Australia. So finding times for us to connect, it was a bit of a challenge. We're going to be discussing her paper titled Thoracic Manual Therapy Improves Pain and Disability in Individuals with Shoulder Impingement Syndrome compared with placebo, a randomized controlled trial with a one-year follow-up. This was published in a good journal. It was the Archives of Physical Medicine and Rehab in 2022. So Suzanne, you and I know each other fairly well, but I'd love for you to introduce yourself to our audience. Tell us what you're doing now. Tell us your research background, please.
Thanks, Chad. Great to be here. I'm Suzanne Snodgrass. I'm a physiotherapist. I'm originally from North Carolina, where you are now, and did my physical therapy degree at UNC Chapel Hill. And after working in private practice and outpatients, I did a bit of traveling, met my husband, who's an Australian, and ended up in Australia. So I started at University of Newcastle when the program began and have been here 20 years now, and I'm now head of the program at University of Newcastle. And in terms of research, I'm interested in manual therapy, as well as any sort of physiotherapy intervention. And currently I'm looking at some studies in balance, which we can talk about later if we have time.
Okay. And you're also heading up the PhD program there, if I'm correct.
Yeah, correct. So I'm deputy head of school for research training. So that means I sort of oversee all of the students who are enrolled in PhDs across all of our 10 disciplines, actually, not just physiotherapy.
Okay, well,
Yeah,
that's
we have about 90 PhD students at the moment.
Yeah, that's absolutely ridiculous. I did a quick look on PubMed earlier today, and you have over 110 publications. So how are you doing all of this? What's your secret?
Yeah, I saw that you wanted to ask me that question. And I think for one thing, I probably don't have good work-life balance. But I think the way the publications have happened over the years is I supervise a lot of research students. And in Australia, the PhD programs are highly embedded in research. So they involve you mentoring a person through a research journey where they might produce 3 or 4 publications as part of their PhD. And because I've done a lot of that, that's built up over the years. I also supervise a lot of honors students. So we have similar honors programs to programs in the United States where students might do a small research project as part of their degree. I supervise about 4 of those a year, and I like to try to turn those over into publications as much as we can. Sometimes they're a bit small and we don't, but where I can, we try to turn those into publications as well. And so I guess over the years that's built up.
So before we discuss the specifics of your paper, was this one of those projects in which you were supervising either a master's level or a PhD level student?
Correct. So this was a clinician that came to me with an idea that came out of their clinical practice and wanting to understand the evidence that there might be for what he was doing. And yes, so this was someone I supervised through their PhD.
Perfect. Let's dig in. This was a 3-arm randomized controlled trial with a 1-year follow-up and also a 6-month follow-up. And then interestingly, you had, I think, muscle energy technique in one group, muscle energy technique and soft tissue mobilization in another group, and then detuned laser, I think, was your placebo for the third group. Tell us a little bit about your study. Where did this idea come from? And give us the provenance behind that.
Sure. Don came to see me because this was an idea that came out of his clinical practice. And Don's an osteopath, so it came out of some osteopathic techniques. In physio, we think a lot about regional interdependence and how other areas of the body might affect another area of the body, but that regional interdependence is a real tenet of osteopathy. And he'd been doing some work in the thoracic spine on his patients with shoulder pain and getting really good results. And so he wanted to have a look into that. And I guess where we started was our hypothesis was that the posture of the thoracic spine affects how the shoulder functions. And initially, we did a radiographic X-ray posture study looking at thoracic spine posture in individuals with subacromial pain syndrome and healthy controls, and found that there was more kyphosis in those who had the shoulder symptoms. And that led us to doing the RCT. Now, in terms of the actual technique, we talked a lot about doing a multimodal intervention, but we really wanted to see what the effect was of that specific technique, that specific manual technique. So we didn't add the exercise, because then you wouldn't know whether it was the exercise or the actual manual therapy. So we chose to stick just with the manual therapy. We had a third arm because Don really believed that the soft tissue work he was doing was also part of what was helping the shoulder. When we talk about the results, we'll see that wasn't the case. So we had basically the muscle energy technique arm, the soft tissue mobilization and muscle energy technique, and then a placebo group. And we really thought the placebo group was important to have in a manual therapy study, because a lot of what you do with the patient is them coming into the clinic, talking to them, that experience of just coming to see a physio. We wanted to make sure we accounted for that amongst the groups. So that's why we chose to have a placebo. We also wanted to have a placebo that didn't have any hands-on component, because in some of the manual therapy disciplines, they have a belief that any sort of hands-on, no matter what you do, is still doing some sort of treatment effect. So with the detune laser, it just lighted up and didn't really do anything. And we didn't even touch it to the skin. So we just held it just right above the skin, and it made some beeping noises. It was actually had quite a strong placebo effect.
Excellent. And you captured a lot of different outcomes. Do you mind walking through those?
Sure. So our primary outcome was shoulder disability, and we used the DASH, which is the Disabilities of the Shoulder, Arm, and Hand questionnaire. As a secondary outcome, we also used the SPADI, the Shoulder Pain and Disability Index. And then we looked at pain using a visual analog scale. We also included a global the GROC, the global outcomes. Oh, I can't remember the GROC.
Global rating of change, right?
Yeah, global rating of change.
Yeah.
And then also patient-specific functional scale. So mainly we looked at the disability questionnaires because they, as the primary, because they are standardized and considered to be reliable and valid. But we did also want to look at pain as well, so we included that.
And didn't you also look at posture too? Did you do a measurement for posture?
We did, yes, we did. We measured the thoracic posture, and we also measured thoracic range of motion, inflection, and extension. Now, we only measured those at baseline and discharge. We didn't continue to measure those in our follow-up time. So we only have the short-term outcomes on those.
So a lot of different measures you captured. Tell us what you found. What'd you find at discharge, 6 months and 1 year?
Yeah. So at discharge, we found that the muscle energy technique group and the muscle energy technique with soft tissue mobilization both had a good effect. So they had a reduction in disability, they had a reduction in pain. And generally, these outcomes held true through the follow-up time periods, which were 4 weeks after treatment, 6 months, and 12 months. At 12 months, only the MET only group, so the one without the soft tissue mobilization, still had a significant difference at the 12 months. For some reason, the MET and soft tissue mobilization didn't have that difference at 12 months. In terms of pain, we didn't see the same significant effects that we saw for the disability questionnaires, but we did see a reduction in pain with the treatment and didn't hang on quite as well towards the 12 months. In terms of the global rating of change, again, saw those results for the soft tissue, for the MET and the MET plus the soft tissue mobilization group. So the intervention groups both had an effect, but it's just the MET only group was the one that held on a little bit longer.
Yeah, what are your thoughts on that? Why do you think? I mean, first of all, you actually found something significant where most people that have used manual therapy to the thoracic spine have not. So what are your thoughts? Is it the muscle energy technique, or maybe having a placebo group and or not incorporating exercise? What are your thoughts on that?
So I think a big difference in our study compared to others is we only recruited people aged 40 and older in the study. And the reason we did that was because a few things. The subacromial pain syndrome has a much higher prevalence in those over 40. And studies of posture in normal populations across the age span will show that the thoracic kyphosis in general starts to be more prevalent in the 40s, 50s, 60s, 70s. So if you look at posture across normals, that's when our posture starts to sort of round. And our hypothesis was that over 40, you get a lot more people with subacromial pain syndrome that have that insidious onset where you don't sort of know what has started it. They haven't had a traumatic event. They often haven't had any repetitive activity that they're doing. Whereas in the younger populations, you see it a lot more in sporting people where they're doing overhead activities and throwing and things like that. And they tend to have, or people at work where they're doing a lot of lifting and things like that. So we think the etiology is a little bit different, perhaps, for subacromial pain syndrome in the older population. And that's why we limited our posture study to that population as well. And we don't think we would have had the same effect of the technique if we included all ages. So we think it's perhaps an etiology of subacromial pain syndrome in the older cohort that means that posture is the thing, or mobility of the thoracic spine might be the thing that's really contributing to their shoulder symptoms.
Yeah, that makes good sense. And I know Don was probably instrumental in providing the clinical care on that. Did you have any opportunity to interact with the patients in the study too?
Yeah, so I didn't interact with the patients at all. And I think, one thing we become concerned about when clinicians do something that they're enthusiastic about is there going to be some bias in, what they're doing? And I think with this one, Don really believed that the muscle energy technique with the soft tissue mobilization was going to be the thing. That was what he was doing in practice. And so I think it surprised him that it was more the muscle energy technique on its own. You didn't really need the soft tissue mobilization to the shoulder for that to actually make a difference. So I think in terms of bias, I'd like to think we didn't have too much bias there. And we presented all three techniques, including the placebo, to the participants as something that was going to help their shoulder pain.
Okay, yeah.
And then we also asked them if they believed it was a genuine intervention for all the three arms. And basically everyone felt it was a genuine intervention except for 4. And it was actually 2 in one of the active treatment groups and 2 in the placebo group.
Wow.
So people who thought it wasn't genuine were within both of our groups.
Yeah, balanced. Very nice. And did you find any differences in posture over the length of the study?
Yeah, we did not find any differences in posture. And the posture was measured by someone who was blinded to group. So a different person, not Don, who was delivering the interventions, but another osteopath who we trained in the measurement. And yeah, there was no difference in posture over that 4-week time period, which was the time period of the intervention from baseline to final session. And no difference in the range of motion of the thoracic spine in that time either.
So I'm really interested in this muscle energy technique, and I know that you have no time to be in the clinic now with all your administrative burdens and research burdens. But if you were in the clinic now, would you consider incorporating this on your patients over 40 with impingement?
Yeah, I think in any patient over 40 with impingement, I would certainly include some type of manual therapy to the thoracic spine, something to get it more mobile. I can describe the treatment for you a little bit. And when I look at the treatment, it's an osteopathic style treatment. And I would see it as a little bit like a segmental mobilization to the thoracic spine with an element of muscle energy. So I think any sort of technique that you might be comfortable with that would increase the mobility of the thoracic spinal joints would be what I would incorporate with the shoulder pain person. And if you're curious about the technique, we've got quite a detailed description of it in the paper, as well as a reference to a text that actually describes it as well.
Yeah, the paper is actually really nicely done. And you know, being a kind of a research junkie, I love your tables. And so what was your software program for those tables, if you don't mind me asking?
We used Stata, S-T-A-T-A, Stata. So Stata is used by our statistics support here. And actually, Don did a statistics degree while he was doing his PhD. So he liked to use that software.
Yeah, and I invite everybody to read these. We always add the link associated with the podcast. So it's definitely worth a read just to see how nice those tables were. Suzanne, hindsight's 2020. I mean, would you do anything different knowing what you know now with this study? Would you change any of the designs?
Well, if I had all the money to do what I wanted to do, I would love to have a larger study where you could actually tease out each element of the intervention. So having an arm that was the soft tissue mobilization only, perhaps. I mean, not knowing what I know now because it didn't seem to add anything, but in the start, we kind of wanted another arm that had that only, and having an exercise arm so that we could see how the manual therapy compared to an exercise arm as well. The other thing I would have loved to have done is measure the posture over that 12 months, because my hypothesis is that perhaps because the thoracic spine became more mobile or more comfortable for them to move, maybe over the time they were just moving more freely and might have changed their posture or range of motion further down the track, but not in that first 4 weeks, perhaps.
Let's say you were
Just
at
or why you might get a result that far down the track.
Let's say you were at an osteopathic conference, you're in the elevator, a bunch of trainees were in the elevator with you. They recognize your name, they recognize your study, and they ask you about it. You had 1 minute to give them the summary of the study. What would you say?
Yeah, well, I'd say in individuals who have subacromial pain syndrome who are over 40, we found that muscle energy technique had a good effect on their shoulder pain over the short and long term. And so we'd recommend doing some sort of manual therapy to the thoracic spine if you have a patient who comes in with subacromial pain syndrome and they are over 40.
Awesome. And hopefully someday we'll get you on so you can talk about that force paper you did on manual therapy too, about how force changes the outcome as well. So we've got time. I'd love to hear where you're going with this balance research that you're doing.
Yeah, sure. We've taken balance measures in some of our neck pain studies, and to have a look at some of those outcomes, look at the papers that were led by Rutger Dezote. But what we found with idiopathic neck pain, even though there's some evidence that shows that balance is different for people with neck pain, for the idiopathic neck pain people, we didn't really find a difference between our groups at all. But what we did see is that there's a huge amount of variability in a person's ability to balance across people and across different age groups. It doesn't seem, even though we know that balance slowly declines as we get older, there's a huge variability. Some people have really good balance well into their 60s, and other people their balance starts to decline in their 30s and 40s. There's some evidence of that. So I've become really interested in being able to identify those people who get on that balance decline trajectory early so that we can do some interventions to actually improve their balance and reduce the risk of falls before it gets too high risk, like when people have comorbidities in the over 65, because a lot of the falls prevention stuff looks at over 65. And I think in middle age, where we are now, we should probably be doing something to keep ourselves healthy and balanced. So we're doing some studies now looking at the different inputs to balance. I'm working with Gordon Waddington at University of Canberra using his ankle proprioception device, looking at some vestibular input, looking at the brain activity during balance using FNIRS, and trying to work out of these components, what are the main components that maybe seem to be the ones that pick up balance decline early, and can we design a clinical test that we could use in the clinic as a quick screen to identify those people who are on a poor balance decline trajectory, and add some interventions to our exercise interventions to help improve that.
Well, that sounds like a very fundable initiative, or is that something you're pursuing with us?
Oh, of course, pursuing. And I'm also collaborating with the guys in psychology as well, because there's this link between cognition and balance. And we're doing cognitive tests to see if this has some sort of link with dementia as well down the track.
Well, that's superb. It's fun talking with you. You always have something going on. This one's a new one. I didn't know you were doing that, but I love hearing that. Suzanne, thank you so much.
Grabbing shiny balls and, like, you know, the next shiny ball.
Or the spinning bowls is what I'm thinking.
Yeah. Maybe so. Maybe so.
Suzanne, thanks for being on, and thanks for sharing your work with us. If someone wanted to follow you or reach out to you, what's the best way to contact you?
Yeah, sure. I think the best way to find me is via the University of Newcastle website. My profile stays up to date because it's fed by all these machines that get the pubs in there and stuff. And my email's there. That's probably the best way to contact me. I do go on to Twitter on occasion, but not really regularly. So probably just grab me via email and find my profile there if you want to find all the publications we've been discussing.
Awesome. Once again, thank you so much for being on Shop Talk.
Great. Thank you.